So good evening, everyone. Good evening, Prof. You are all welcome to this week's presentation where Dr. Magaji, a resident in surgery at Federal Medical Center, Jabi, Abuja, will be presenting on the topic Principles Involved in Organ Transplant. And after his presentation, we are going to entertain comments from all the participants, after which Prof will now make his own final comment before we now close for the day and announce subsequent presentation. So Dr. Magaji, you can proceed.
All right, sir. Good evening, Prof, consultants, senior registrars, and registrars present. My name is Dr. Magaji, a registrar in Department of Surgery. Today, I will be presenting principles involved in organ transplant. I'll be using this outline from introduction down to the principles, which involve pre-op, intra-op, post-op complications, some ethical considerations, then challenges in West Africa, and then conclusion. So by way of introduction, transplantation is the process of transferring an organ, tissue, or cell from one place to another. While an organ transplant is a surgical procedure in which a failing organ is replaced by a functioning one. So definition of terms, autograft. An autograft is a tissue, cell, or organ that is gotten from one part of the body to another in the same individual, while an allograft is an organ or tissue from another individual of the same species. Then an isograft is an organ or tissue gotten from one individual to another identical individual, genetically identical individual. Then xenograft is a tissue or organ from a different species that's been transplanted to an individual. Then autotopic graft is a graft from an allograft that is being transplanted into the same anatomical location that is gotten from the donor, while a heterotopic graft is a transplant of an organ in another anatomical location. So transplant immunology, the immune system protects against foreign body. It rejects transplanted cells, tissues, and organs as it recognizes them as foreign body. Just the same way the immune system attacks microorganisms. So also, whenever there is a foreign body in one's body, the immune system attacks such a foreign body. The antigens are recognized by the body's immune system and respond by producing antibodies, cytokines, or via cellular mediated process that rejects or eradicates the graft. So it is important we understand the immunology of transplants, because understanding of this transplant immunology had led to a significant improvement in graft survival over the years. The main antigens that are responsible for rejection are the HLA antigens. Basically, there are two antigens, the HLA antigens and the ABO blood group antigens, but the HLA antigens are the main antigens responsible for rejection. They are part of a histocompatibility complex, which encodes the HLA antigens. They are surface proteins. The histocompatibility complex are located on chromosome 6. They are divided into two classes. There is class 1, A, B, and C, which are expressed by all nucleated cells, while class 2 antigens, we have the DR, DP, and the DQ, which are expressed by antigen-presenting cells, that's macrophages, B lymphocytes, and then dendritic cells. So it is important to note that HLA-A, B, and DR are the most important in transplant surgeries. Then the ABO blood group antigens, They are expressed not only on the surface of red blood cells, but also on endothelial cells. So by extension, this means that all transplants should be that the grouping and cross-matching should be done, because if there is a transplant with an incompatible donor, the end result is a hyperacute rejection. So the cells involved in the transplant immunology are categorized into three: the lymphocytes, which which we have the T lymphocytes, B lymphocytes, and natural killer cells. The T lymphocytes are the most important because they are the first contacts, which now differentiates into CD4, CD8, and then natural killer cells. A subset of the lymphocytes also produce cytokines that stimulates B lymphocytes to produce antibodies against the invading antigen. So the T lymphocytes are the targets in immunosuppression in transplant. So we have also antigen presenting cells, macrophages, dendritic cells, and B cells. Then the effector cells, which are neutrophils, macrophages, and T lymphocytes. Graft rejection. The T lymphocytes and antibodies produced against graft antigens react against and destroy the tissue grafts. There are basically two pathways in which the T lymphocytes recognizes these antigens. There is the direct pathway and then the indirect pathway. This picture depicts the direct pathway. In the direct pathway, the antigen presenting cells are from the donor. So they present the antigen just the way it is without without processing it. So they present it to the recipient's lymphocytes, which now become activated and eventually leads to the rejection of the allograft. While in the indirect pathway, the antigen presentation is done by the recipient's presenting cells. So the antigen presenting cells here, they ingest and then process the antigen. Then they now present the antigen to the T lymphocytes, which now become activated via a series of reactions, production of interleukin-2 specifically, that leads to proliferation of a clone of T lymphocytes, which at the end of the day produces cytotoxic cells that now affect the killing of the invading cells, as well as producing cytokines that stimulate B lymphocytes, which differentiate into plasma cells that now produce antibodies against these invading antigens. So there are three types of rejection. We have the hyperacute rejection, acute rejection, and chronic rejection. In hyperacute rejection, it is a very rapid type of reaction. It occurs usually within minutes to hours after organ reperfusion. It is triggered by preformed antibodies in the recipient's serum, which now attack the HLA antigens or ABO blood group antigens. There are certain risk factors that predispose to hyperacute rejection. These risk factors are previous failed transplant, if there is previous blood transfusion, or multiparous women. All these risk factors tells us that the patient has been exposed to these antigens and then now developed antibodies against those antigens. The second one is the acute rejection. Is the common type of rejection. Usually occurs within few days or weeks after transplant. Based on the mechanism involved, we have three types. It can either be cellular, humoral, or a combination of cellular and humoral mediated rejection. The third one is chronic rejection. It is a slow type of rejection. It can manifest within the first year of transplant, but most often progress gradually over several years. The mechanism is not well understood, but however, pathologically, there is evidence of fibrosis, and thereby, at the end of the day, As once the organ is fibrosed, it leads to loss of graft function. So we now go into the preoperative principles, which entails patient selection and evaluation, patient counseling, as well as the donor counseling, informed consent from both the donor and the recipient, and then optimization. So patient selection and evaluation. To the recipients, patients, number one thing is to have an indication. The patient must meet an indication for the transplant. That is, the organ must be failing. There must be an organ failure. Then the patient will now be evaluated clinically on history and physical examination throughout diseases and comorbidities, because presence of some of these diseases or comorbidities may hinder the surgery or may predispose the patient to complications that may eventually lead to mortality. So it is vital that we take adequate history. Then immunological evaluation, first we do serology, HIV, hepatitis, CMV, and VDRL. It is important to note that uh, before HIV patients, well, yeah, HIV infection is a contraindication to transplantation. But however, with the current use of highly active antiretroviral therapy, it is not a contraindication to transplantation. For other infections such as hepatitis, presence of active hepatitis is a contraindication to transplantation. However, for those with chronic carriage or chronic inactive hepatitis, it is not a contraindication. The patient can be placed on antiretrovirals. Then tissue typing and cross-matching, which is very important, without which it may lead to organ rejection as well as blood grouping. Then infection screening, because post-operatively this patient will be placed on immunosuppression. It is important to identify and treat sepsis wherever the source is, and then also screen this patient for TB because they will be predisposed to immunosuppression. And TB is one of the opportunistic infections. Help in optimizing this patient includes food blood count, protein profile, tests of renal function, tumor markers to detect any malignancy. Because by the time these patients are immunosuppressed, if there is a malignancy elsewhere that is not apparent before this transplantation, the malignancy may progress because immunosuppression also helps in progression of tumors. Then stool microscopy, looking for intestinal worms, if any present, should be treated before transplantation. Then ECG, as is indicated, especially those with hypertension or hypertensive heart diseases, and then fasting blood sugar. Then to the donor, there are two types of donors. There is the living donors and then the dead donors. The cadaveric donors are divided into two. We have donation after brainstem death and then donation after circulatory death. We'll be discussing these ones in due course. Donation after brainstem death. By definition, brainstem death is defined as permanent loss of capacity for consciousness and spontaneous breathing. So as soon as we have a candidate brainstem death that we think is a candidate for organ donation, one has to establish that yes, there is brainstem death. Then secondly, exclude other causes of coma, which includes hypothermia, some drugs that depresses the central nervous system, intoxication from alcohol, hypothyroidism, encephalopathy, whether from uremia or hepatic encephalopathy, as well as hypoglycemia. So having ruled out this, then the patient can now undergo a test for brainstem death. It's explains the clinical tests for brainstem death. Basically, we test for three things. Number one is the cranial nerve with the exception of cranial nerve 1 and 12, which require consciousness. Then motor response. And then the third one is apnea test. So donation after circulatory death. So donation after circulatory death describes the recovery of organs for transplantation after death confirmed by circulatory criteria. The modified Maastricht classification is widely used to categorize this type of donors. This slide explains the categories using the modified Maastricht classification. We have 5 categories, and these 5 categories can further be grouped into 2. Group 1 is the controlled death, and then the group 2 is the uncontrolled. The uncontrolled are those that have had unexpected cardiac arrest, unexpected irreversible cardiac arrest. Then the controlled group is the patients that you anticipate cardiac arrest, and then one withdraws life support from this patient for the purpose of organ donation. So category 1 is death on arrival at hospital. Category 2 is unsuccessful resuscitation after cardiac arrest. Category 3 is anticipated cardiac arrest after withdrawal of support. This category 3 is the main category that is being used for organ donation. Then category 4, cardiac arrest in brain dead donor. Category 5, unexpected cardiac arrest in ICU. So for the living donors, we have 2 categories, either related to the recipient or unrelated to the recipient. These living donors must be thoroughly evaluated using history, physical examination, and relevant investigations. So there are some contraindications for living donor. If that donor has a mental disease, if the organ to be donated is deceased, and then if there is incompatibility, either ABO or HLA incompatibility, presence of any morbidity or mortality risks, then presence of transmissible diseases like HIV, hepatitis B or C. Then if there is active malignancy or malignancy in the last 5 years, here there is exception to this rule if the malignancy is not from tissue that metastasizes, especially primary brain tumors, in situ cervical carcinomas. So those are some of the exceptions to this rule. So having done this, the next thing is to do a tissue typing. Then the tissue typing laboratory is carries out 3 tasks. The first task is to determine the HLA type of blood for both donor and recipient by PCR. Second is lymphocyte cross-matching to exclude circulating antibodies in recipients against the HLA expressed by the donor. Then the third task is HLA antibody screening. So now counseling and obtaining consent. It is important to note that at times professional counselors or psychotherapists have to be involved. Then the main aim is prevention and minimization of possible complications that may arise to both the donor and recipient. Then there is the recipient. On the recipient side, there is need for adherence to post-op maintenance medications. This must be emphasized to the recipient and his relatives. Then regular follow-up is required, lifestyle modification, cessation of smoking, abstinence from alcohol ingestion, sedentary lifestyle. Because you can't give a transplant, say for example, a liver transplant, and then the patient now starts taking alcohol, which we all know that it has damaging effects on the liver, as well as smoking. It's a risk factor for endothelial damage, which may later predispose to atherosclerosis and other complications. Then counseling the living donor, it is important that the donor be educated adequately concerning the procedure itself and all that it entails to donate an organ. Then it must be emphasized that it is not based on financial grounds, and the patient, the donor must not submit uh, to the donation under duress. So it has to be willingly. He shouldn't be forced, and there shouldn't be any financial attachment to the donation that he's about to make. Must undergo extensive screening. The donor should understand that the process is not actually easy. There are a couple of investigations that he has to undergo before actually donating the supposed organ. Then the family must be involved and carried along. Surgery and anesthetic complications must be explained to the donor as well as to his relatives before obtaining consent. So to a deceased donor, there are some factors that influence refusal of consent by relatives. Number one, non-acceptance of brain death. It's not everyone that accepts brain death. Some relatives believe that once there is a sign of life, the patient is not dead. So as such, this is a strong factor that influence refusal of consent. Then there are some superstitions relating to being reborn with a missing organ. If someone has donated an organ, some people believe that his children or the generation to come may have that organ missing because of that donation. Then delay in funeral. Some may want to bury their deceased immediately. However, if there is a pending organ donation, there may be a delay. So this may stand as an obstacle to consent for donation. Then lack of consensus within the family members. Some may agree, some may not agree. Then fear of social criticism. Some of these relatives may be criticized. Probably people may say, okay, they have taken their brother or sister to donate organ, they have used it for ritual and all other things like that. Then dissatisfaction with hospital staff. Some may not even trust the hospital staff. Some believe that certain hospitals actually are occultic hospitals. So these are some of the concerns. Then religious and cultural concerns. The recipients, the nature of disease and the need of transplant should be explained in details to the recipients. The outcome and complications of the procedure, as well as the complications that comes with immunosuppression, has to be emphasized. Need for compliance for immunosuppression, as I've mentioned earlier. Then if there is any other available option. So optimizing the patient, just as we do for every other surgical patient, it is paramount that certain derangements be corrected if they are present, such as anemia, dehydration, uremia, then treatment of infection if it's present, because by the time the patient undergoes surgery, the stress of surgery, that of immunosuppression, so there may be an overwhelming infection. So all infections must be treated. Deworming of the patient, central line and catheter, urethral catheterization are very important, especially for those going for renal transplants. Then loading dose of immunosuppression is given 12 hours pre-operatively and prophylactic antibiotics. So intraoperative principles are basically two: organ procurement and preservation, and then transplant and vascular reconstruction. For organ procurement and preservation, for living donors, strict asepsis and hemostasis has to be followed. There should be adequate exposure, then followed by control of the vessels above and below the organs. Then removal of the organ. Having removed the organ is now preserved and then packaged in a sterile manner. For deceased donors, we have two categories: donation after brain death. For this category, the mobilization of the organ is done first, then perfusion. While in donation after circulatory death, preservation is done first, then mobilization of the organ. So this picture depicts an adequate exposure in a diseased donor. It's a median thoracotomy incision that extends to a midline laparotomy incision, exposing the desired organs. On the other side here shows a catheter passed through a femoral vein. It has two balloons. There is one superior up there and then one inferior, which now occludes the aorta. Then to the other side is the inferior vena cava. A catheter is passed so as to introduce the preservative. So preservation of the organ so collected or harvested. After removal of the organ is flushed with a chilled organ preservation solution. The gold standard is the University of Wisconsin solution. That is the gold standard that is used for preservation of organs. There are other preservatives that are used. These preservatives have some certain constituents. There are electrolytes there, buffers, as well as impermeants. There are four basic methods of organ preservation. The first method, which is the traditional method, is the static cold storage. Then we have the hypothermic machine perfusion, pneumothermic machine perfusion, and pneumothermic regional perfusion. So for static cold storage, here, having harvested the organ, the preservative is introduced into the vasculature to flush, first of all, flush the microcirculation and then keep the organ at a very low temperature of about 4 degrees Celsius. So with time, there have been advances. People now advance to the hypothermic machine perfusion. In this method of preservation, the organ is placed in a sterile chamber, as we can see here in this machine. Then the chilled solution is now introduced and recirculated through the vasculature of the organ. This is in such a way the circulation the circulation actually flushes the microcirculation, thereby leaving it without any debris. The pneumothermic machine perfusion is similar to the previous one, that's the hypothermic machine perfusion. But in this instance, the solution that is used is actually body temperature and it contains red cells. And some machines include also oxygenation. So there will be continuous recirculation of this preservative solution. Then the last one is the pneumothermic regional perfusion. Here is used in donation after circulatory death. So after a cardiac arrest, the desired organ is cannulated and then a pneumothermic, the patient's blood is being circulated through the organ. So transplantation and vascular reconstruction, this basically, in this place, the surgeon adheres to the principles of vascular anastomosis. It is important to note these two important terms: warm ischemic time and cold ischemic time, as it applies to transplant surgeries. The warm ischemic time of an organ is that the time an organ remains at body temperature, between which the blood supply is cut off before cold perfusion, usually within 30 minutes. So extension of this time may predispose to ischemia, and subsequently there may be delayed organ function or even primary organ dysfunction. Then the cold ischemic time is the time between the chilling of the organ and then the time the organ is reperfused. Then optimal cold storage times for various organs. As we can see from this table, kidney has the highest storage time. Then heart has the lowest time, about less than 3 hours. The safe maximum being 6 hours. Post-operative principles. Post-operative assessment of the patient. As with all other surgical patients, clinical assessment is very important. Vital signs, if there is presence of fever, tachycardia, hypertension, pain at the site of implants, these are pointers to likely rejection or presence of a surgical site infection. Then if there is pedal edema, it may indicate compression of external iliac vein. This applies to kidney transplant patients. Then if there is oliguria or anuria, one will also suspect that the organ is actually either there is a delayed function or there is an irreversible damage to the transplanted organ. Then investigations, EUCR is very important, especially in renal transplant patients. Ultrasound scan is done when one suspects that there is an organ rejection. Certain things that will be seen is pelvic axial dilatation. There may be fluid collection around the transplanted organ. Then ultimately, biopsy of the transplanted organ will confirm the diagnosis, presence of mononuclear infiltrates, then fibrinode necrosis or interstitial hemorrhage. Other post-operative principles, maintenance immunosuppression, which is very, very, very important, DVT prophylaxis, treatment of infection, and regular follow-up. So we now go to immunosuppression. The principles are the same. Whichever organ that is being transplanted, they are the same. Agents used to prevent rejection are predominantly the agents used are predominantly attack the T cells because as we have seen from the immunology of transplants, the T cells are the primary cells that actually mediates this transplant rejection. So the target is on the T cells. So there is the need for immunosuppression in the first 3 months. But however, we still need maintenance. Then it is important to note that immunosuppression predisposes to infection and malignancies. These are classes of the drugs used for immunosuppression. We have the immunophilin binders. On that, we have two categories, the calcineurin inhibitors, cyclosporin and tacrolimus, then the non-inhibitors of calcineurin, which is sirolimus. We have the antimetabolites, azathioprine and mycophenolic acid. The side effects of some of these drugs, the antimetabolites, they depress the bone marrow. So as such, we should expect anemia, leukopenia, which will later predispose to all kinds of infection, and probably thrombocytopenia with bleeding tendencies. So these are the side effects of these categories of drug. The calcineurin inhibitors are known for nephrotoxicity. Then we have biologic immunosuppression, in which we have two categories there, polyclonal antibodies and then monoclonal antibodies. These monoclonal antibodies, it is important we know this basilizumab, which is antibody to CD25, which is the receptor for interleukin-2, the chief cytokine that is involved in proliferation of T lymphocytes. Then other immunosuppressants, which are very important, are the corticosteroids. So the regimen used for immunosuppression, we have those used for induction, maintenance, and rescue agents. So for induction, we have the calcineurin inhibitors plus a CD25 monoclonal antibody, which is an antibody to interleukin-2. There is triple therapy, where we use calcineurin inhibitors, antiproliferative agents, and steroids. Then there is a dual therapy, which involves use of calcineurin inhibitors, uh, steroids, and mefolanic acid, then polyclonal antibody. For maintenance, there is the mTOR inhibitor, which is the mammalian targets of rapamycin inhibitors. It's actually a target because this mTOR, it's involved in the pathway of interleukin-2 receptor transcription. So blocking this pathway actually blocks all signals of interleukin-2, thereby blocking proliferation of T lymphocytes. We have multi-drug therapy using steroids, antiproliferatives, calcineurin inhibitors, and lymphocyte sequestration. Then in acute rejection, most commonly polyclonal antibody combined with induction regimen. That's quadruple therapy. Complications of immunosuppression. We have infections, as we have mentioned earlier. Some of these agents actually target the lymphocytes, and by extension, the B lymphocytes, which are the chief cells of the adaptive immunity. So by that, these patients are predisposed to lots of opportunistic infections. So bacterial infections, commonly we have community-acquired infections, wound infection, especially post-operatively. This patient tends to have surgical sites infections, urinary tract infection, especially if catheter is used for a prolonged period. Then tuberculosis, either primary infection or reactivation. Viral infection, it is highest in the first 6 months. The commonest virus infection known for herpes zoster infection. Then also, for which reason some of these patients are placed on cotrimazole therapy, just the same way patients with HIV infection are placed on cotrimazole for at least 6 months to prevent infection by pneumocystis jirovecii. Then parasitic infections. Malignancies of note is the PTLPD, that's the post-transplant lymphoproliferative disease, which is seen in 1 to 3% of kidney transplants with about 50% mortality. We have other unpaid donation. Some people from the villages and then exploiting them to come and donate organs, give them chicken change. So unpaid, it should be willingly, donation should be willingly. Then fair procurement of cells and tissues. Donation of organs and selection of organ donors should follow due process. There shouldn't be discrimination, whether ethnic, race, regional, or whatsoever kind of discrimination. It should follow due process. Once once a donor is eligible, the person can go ahead with donation. Then stewardship of donated cells and tissues. In well-developed countries, there are organizations that actually handle these donated organs. Then quality and safety of the cells or tissue harvested should be of a standard quality. This is just to protect the patient, because you can't go and harvest an organ, transplant it to a patient. At the end of the day, the organ is either diseased or not even safe for the recipient. Then fair distribution of processed cells and tissues. Like I've mentioned, these organizations are there to ensure that once these organs are harvested and they have data of patients on waiting list for donation. So they compare these donated organs and the tissue type, the HLA and ABO blood groups. They compare these, the donated organs, and then the recipients on the waiting list. Once there is a match, these organizations locate these patients and distribute these organs the way it should, without any discrimination. Then concerns over non-life-saving or non-vital tissue organ transplantation. This involves probably transplants, facial transplants, or transplants of some parts of the limb that have been attempted and done in some parts of the country. So there are concerns regarding that, the religious and cultural concerns. So current and future trends, genetic engineering. Currently, researches are ongoing to in order to increase the amount of donated organs, because there is shortage of these organs for transplant. So doctors are trying to explore more options. The closest species is is the pig. Is the pig. Researches are ongoing. Initially, uh, it was found out that there is a particular antigen, the galactose alpha 3 galactose, which is the main antigen that predisposes to uh, transplant rejection. So that antigen was actually knocked out, and then transplant was attempted. Still, there was rejection. So they later found out that there are two more other antigens that needed to be knocked out. So these two other antigens were knocked out in a condition known as triple knockouts of this antigenic allogens on pig. However, even with this, transplant was attempted, and some of the recipients died few weeks after the transplant. Some had transplants, heart transplants, some kidney transplants. Some of them died few weeks to few months after the transplant. So there is still need for more research to be done, especially in the field of transplant immunology, to come up with agents that can actually suppress this antigenic effects, or to come out with better ways or better genetic engineering that will assist in later future to have enough organs for donation. So there are some challenges in the African countries, especially West Africa, because of immunosuppressive drugs and the ability to perform adequate matching of donors and recipients. Most countries don't even have the lab to do the tissue typing. Then because of the drugs, most of our patients cannot even afford to maintain the immunosuppression. Some even to afford for the transplants, they can't afford. And most of our governments, there is lack of funding or subsidy as regards to these transplant surgeries. And there is lack of legislation regarding disease donation and transplantation, as well as a lack of registry in most African countries. In well-developed countries, there are registered organizations that actually look for and take care of donated organs and distribute them accordingly. Then staff migration from most of our from most of the West African countries, traveling abroad for greener pastures. So these are some of the factors contributing to transplant surgeries in our country. In conclusion, organ transplant is a successive therapeutic option for treatment of end-stage organ disease. Success depends on improved surgical technique, immunosuppression, organ preservation, and follow-up. These are my references. Thank you for listening.
Okay, thank you very much, Dr. Magaji, for the presentation. You did well. Before we go into questions, comments, and contributions, from the content of the presentation, we could see that transplant is involved. It involves a lot of socio-cultural factors that will impair the process of transplantation, and it has a lot of expensive preoperative evaluation, and the expertise and technicalities that are involved in transplant surgeries are also things to consider. And it's overall, it's a capital intensive project or process, and also challenges of availability of donors, both live donors and cadaveric donors. And of course, which what you don't mention is a multidisciplinary team approach, because in centers where transplants are being done, you see a lot of challenges during the patient preparation. So Dr. Magaji, well done for the presentation. You did well. We are going to entertain comments, questions, and contributions. So the floor is open for any comments, questions, contribution. So you can lift up your hands. Or we can just go ahead and unmute ourselves and ask questions. Yes, any questions, any comment? Okay, we are not receiving any comments. Maybe I should just hand over to Prof, though I saw a message that was dropped by Prof. I don't know if his network is back. Hello, Prof. Okay, there are some points that was raised, that was mentioned. Prof dropped a message that my network is fluctuating because of the rain this evening. My comment should be read later, not now, especially if I'm unable to get audio. A good presentation for his level. He's highly commended. However, there are gaps arising from his not having managed such cases. It is always good to pick a common organ, for example, and discuss around it. I expected mention of our legal aspect of organ transplant, especially following the recent issue with former Deputy Senate President. But I commend Dr. Magaji for a good effort. That's this Prof's comments. Thank you very much, Prof, for your comments. And we actually have a topic on the principles of liver transplant that is going to be presented by a senior registrar. It's on the schedule. I don't know if Prof's network is back.
I can hear you now.
Okay, sir.
I don't know if you can hear me now.
Yes, we can hear you, Prof.
Yes. Great. I think Dr. Magaji has tried very well for his level. I'm really impressed. As I said, a few things are okay. But before I go to him, it's for the rest of us on this call. We're supposed to read around the subject before we attend, not just attend to listen. So please, I'd like to encourage all participants to spend some time, reading around the topic. So when you come here, it's not like somebody delivering a lecture to you. It's almost like, okay, I'm going to make my contributions when you finish. That's the way to keep everybody on their toes, even the presenter. So please, but that's my first comment to all of us on the call. The residents, they consider this as an opportunity for you to also prepare for the topic advertised and to make your contributions. So like I tried to say, I think Magaji has done quite well. If you have not really been involved in transplants, it looks a bit abstract, but the way to go about it is to look at some of the ones that you start off with the minor tissue transplant, organ transplant, and then you go to something more complex. And I think they're taking the kidneys transplant, which is even being done in this town. I don't know if he was able to get to the renal kidney, the kidney transplant center to ask a few questions. You would have found it much easier to comment on some of the preparations, pre-operative, counseling efforts, and so on. And indeed, what are the post-operative measures adopted? That becomes much more palpable than just reading it in the book alone. And of course, you could see that your references are too few. It's about principles, so I agree that Bedo is very good, but you can get much more if you had communicated with the senior people who are doing this at the kidney transplant hospital in town. Having said so, I want to reiterate again, I agree with you that I think Magaji has tried very well for his level. It was a good presentation. He has a few challenges getting the presentation going. This is something that I think we need to keep practicing to be able to perfect. I'm happy that he had two networks in case one fails, you swing to the other, which is good. But learn to share your slides better than what we saw today. I'll stop here for the moment. I think the area apart from commenting on the Nigerian situation closely, the legislation and so on, I think that he is good. When I was chair of the faculty, we did not insist that you must have done transplant, but we thought it's a good idea to go to where transplantation is being done, to have a grasp of what what it is all about. All these preparation principles you have mentioned are what you will see in practice, and that tends to stick. So don't, I think you have a good opportunity to master the subject by visiting the kidney hospital and seeing what they are doing. And then you can you will find that this will stick for you in your brain for it's bad.
I think we lost Prof again. Hello, Prof. Okay, thank you very much, Prof. I think Prof is having some challenges with his network.
Yes, my network is really bad, particularly the audio.
Yes. But
Yes, but I have largely made the point I wanted to make. I said Magaji has done well, and for his level, but he needed to have visited the kidney transplant center in town to get more information. And I think he can still do so to polish the knowledge on the subject. That's number one. Number two, the participants should do a bit more reading before coming. Yeah.
thank you, sir. Thank you very much
Thanks
for participating. So the presentation for next week will be classification and management of thyroid malignancies. And it's going to be by the senior registrar, Dr. Abdul from Aminu Kano Teaching Hospital. So
fantastic.
Thank you very much. As Prof advised, we should all go and review the topic so that we will have meaningful comments, questions, and our contribution after the presentation. Thank you very much, and yes, have a good night rest. Thank you, Prof.
Thank you very much, and thank everyone, and thank Magaji especially.
Thank you, sir.
Thank you, sir.
Yeah. All right then.